As I go through life, it's an endless stream of special moments and hopes and dreams. I hear a song and it calls to me about the ones I love, friends and family. It's always good to know I'm on my way home. I got you on my mind wherever I roam. So many ups and downs, but there's one thing I know. I'll be with you soon, I'm on my way home. I'll be with you soon, I'm on my way home.
Welcome to this Axxess LinkedIn Live conversation. We're so glad you're here. Axxess is using conversations like this to bring you meaningful discussions on a variety of topics. And we hope you learn something from the experts you meet along the way. We encourage you to join the conversation by using the comments section to ask questions or post feedback. Hi, my name is Deborah Hoyt, and I'm Senior Vice President of Public Policy at Axxess. Today, we'll be doing a look back and analysis of the Medicare Home Health Patient-Driven Groupings Model, also known as PDGM, which went into effect in January of 2020. Home health providers spent much of 2019 preparing for this historic Medicare payment shift by modeling the new clinical requirements and anticipating the updated reimbursement schedule. However, in March 2020, we all know the COVID-19 pandemic hit the country, and that's changed everything. Before I introduce our expert and dive into our discussion, I'd like to thank the Partnership for Quality Home Health Care and credit the Washington, D.C.-based health economics consulting firm of Dobson and DeVonzo for the data findings we'll be exploring today. Axxess is privileged as a member of the partnership to share the Dobson analysis of the 2020 home health PPS claims data to evaluate the transition to PDGM and the COVID-19 impacts on Medicare home health providers and beneficiaries. Now it's my pleasure to welcome my friend and Axxess colleague, Arlene Maxim, a registered nurse, a home health industry consultant, advisor, and analyst, to join me to share her perspective on the Dobson data report. It's great to see you, Arlene. How are you?
I'm good, Deb. Thank you for having me. It's an exciting time in home health, and I hope everyone here listening to this is excited about it as we are, because we have so many things coming up with the industry in itself, and the results of PDGM are striking. And I think we're going to have fun with this presentation today and make people understand what they need to do to move forward.
Thanks, Arlene. So welcome. So I guess let's just jump in. I probably have 4 or 5 questions, and I look forward to hearing your analysis of what's happened over the past year and a half so that we can get better as an industry. So looking back with over a year of experience into the new Medicare reimbursement model, we know the PDGM transition wasn't as clean as the home health industry expected. I'm very interested in your perspective as a nurse with a certificate in home health compliance on what the data show overall and how we can regain our footing as a provider industry more than a year later.
Well, Deb, that's a really interesting question. I think that the data clearly shows that CMS was not on top of the information that they had at hand at the time PDGM started. We spent the whole year of 2019 training staff on PDGM and what to do to get ready, and we certainly thought that that was going to be the highlight of 2020 and then going into 2021. Little did we know that COVID would actually have a huge effect on everything that went on. And then in 2021, of course, we got hit with the no pay wraps. So statistically, CMS was not on target in their projections as to how we would function as an industry. And clearly they have some things to clean up. I was interested in particularly MedPAC's report coming up And they typically bring that report out in July, so we will be seeing something in that soon. And that'll probably give us even more data that we can use to move forward in the next couple of years. But clearly the information that we had going into PD actually experienced in the year of 2020 and then going into 2020.
Significant. And seeing what they are going to be coming out with in terms of this as well. So let's move on to another aspect of the findings that have actually revealed challenges around something called low utilization payment adjustments, also referred to as LUPAs. So LUPAs arose prior to this state-mandated COVID lockdowns, and they've persisted since. So high LUPA rates appear to be a troubling feature Patient-Driven Groupings Model. And we were thinking before the launch of it, that was going to be the case. So just wanted to know your thoughts and feelings on LUPAs and how providers can address this now.
Well, the LUPAs are a problem, and that was probably one of the most significant issues that we looked at going into PDGM. We were concerned about LUPAs, the LUPA rate. Even to this day, I've gone into a number of agencies in the past 2 years, and I find that the industry overall is not real clear on how to make these adjustments from the old system to the new system. The LUPAs for the year of 2020, and I believe we're still feeling it in 2021, are significant. Our rate went up to 15% in 2020. That was shown in the study that we reviewed. And that is not sustainable in most agencies, and particularly the smaller agencies that need to make those LUPA rates almost every time. And most of what I see, and I do believe it was impacted by COVID, are the missed visits that caused the LUPA rate to increase. Patients were not willing to have all of these staff members coming into the home, and some of the nurses were not willing to go out and do visits. So we had a significant number of missed visits that caused the LUPA issue that was exacerbated by COVID. And the PDGM numbers that they came out with and assigned to us for reaching particular LUPA rates relating to diagnosis were impacted by people just not getting the visits in that they needed to be gotten. So I think that this is going to go on for a while, and I do think that agencies need to take the time to study the LUPA rates within their organization, and also determine how they can avoid particularly the missed visits and what we can do with that. I do think that in the future, there's a lot of talk about telehealth. And I do think that if we are able to get reimbursed for telehealth, that's certainly going to help us, and certainly going to help us avoid those LUPA problems. But it has been an issue, and I'm hoping by the end of this year, I believe we're now coming out of the pandemic, and that we'll be able to see our industry recover from all of that.
Thanks, Arlene. I really like your correlation between the missed visits piece and how consumers basically reacted during COVID and their hesitancy to have home-based care workers come into their home to give them the care. And this has been a challenge, but I believe, as you said, we're starting to come out of that, and we're seeing that people really are valuing home care and, all of the different aspects of home-based care that can help them, keep their chronic care conditions managed or address whatever their physicians want them to be doing so that they can have a better quality of life. So the telehealth is also a really important aspect, and I'm glad you mentioned that as well. We're working and advocating as an industry in Washington, D.C. on reimbursement to make sure that the providers of this home-based care not only are allowed to do home-based telehealth visits, to do telehealth visits instead of going into the home, but also get paid for them in the long term as opposed to just during the COVID emergency. So that was really helpful for you to explain that. And I think that that's something that is going to be important as we look forward. So thank you. So let's kind of shift the discussion to coding a little bit. What coding related trends were identified in the Dobson study? And were home health providers optimizing their reimbursement as CMS initially assumed they might under the new coding structure, under the new PDGM coding structure?
Well, that's a really good question, Deb. And the answer to that is there was no change. I think the COVID actually caused a reverse effect that CMS probably thought would happen. We continue to see the same type of coding. Folks are they are sticking with the coding guidelines. And I believe that CMS is surprised that we haven't seen a difference. Most of the clients that we're seeing now in the home continue to have, I mean, we had COVID going on, but they still had wounds and they still had rehab issues. And so the diagnoses themselves, along with the comorbidities that were attached with those, were really important. It's going to give us some really good information in the future. And should this ever happen again to us, we're certainly going to have a lot of information, a lot of data on how to stay away from some of the trends that happened. Hopefully, again, with telehealth is going to be reimbursed for us, and that certainly is going to be helpful. But I think CMS has been shocked at how we didn't, as an industry, behave the way they thought we may behave and make some changes in coding and that type of thing. It just didn't happen. So the coding itself and the types of patients that we're seeing are the same types of patients we have always seen. One of the things that I find when I do record reviews for some agencies is that agencies aren't, they're not watching their visit frequency, and some of their frequencies are just as high as they had been in the past. Some of the agencies are still using therapy as much as they had in the past, which is a problem because therapy now is not reimbursed any differently than any of the other disciplines. So there are some things that happened, and I believe that CMS has been quite surprised. And again, I think it'll be very interesting to see the MedPAC report when it comes out next month and see what type of analysis they've done in the behavior over the past year. And hopefully they'll use the data that the Dobson report has put out for us to take a look at.
Arlene, I really agree with that too. And I think that when we first heard about the patient-driven groupings model coming out and what CMS was thinking in terms of its reimbursement structure, they kept using the word behavioral adjustment. And people don't really normally know what something like that means, but basically what they were saying is that the providers of home-based care were going to be changing their behavior in terms of coding, in terms of how they're scheduling visits and the quantity of visits and the types of visits to modify and maybe play into more beneficial reimbursement. So we didn't see that, and that's just, you know, really important and wonderful. I think that CMS also had a reduction in reimbursement to providers right off the bat, right at the beginning of PDGM, because they thought that they were going to see coding that would be leading to higher spending on CMS's side. So that didn't happen. That's positive. We had a really good, compliant, disciplined home-based care industry that did the right thing for the clients and was really compliant in terms of making sure that this initial rollout of PDGM was really handled properly. So despite a COVID pandemic and the emergency they were dealing with, along with staff and the reaction by the clients, this was really a good outcome. And I do agree with you that MedPAC and some of this Dobson data is something that can be used in favor of the argument of making sure that CMS is not going to be reducing reimbursement to home health agencies as a result of this. So thank you so much. This is really important, and I appreciate your ongoing analysis as we kind of take a look at this moving forward. So we were talking about PDGM and reimbursement. So we know the PDGM reimbursement structure strongly favors the new starts of care over what they call continuing or recertifications of home-based care. Sequences of care were far shorter than anticipated, I guess, in the findings, and early cases were overrepresented in the case mix system. Do you think that this was due to the pandemic, or how will this affect CMS's approach to future provider reimbursement rebasing? And this is really critical to what you were just talking about.
I'm sorry. I don't believe it was because of behavior adjustments. I do believe that, again, it was partly because of COVID. Now, we've got to remember that we've had patients that were hospitalized during the pandemic that became very, very ill. So many of those patients stayed in the hospital longer, which would have, I mean, if they went past their episode period, then they would have had to have been discharged, and then a new start of care would, instead of resumption of care, we would have to do a new start of care. So I think there are a lot of reasons included in the numbers that we see. The recertifications, we don't see as many of those, and primarily it's because of the 30-day billing periods, and folks are taking a more, I think they're looking at that much more closely to determine whether the patient should go into a second 30-day episode. So we see, I believe we're going to be seeing fewer recertifications, but the start of care, because the patients are looking at, not the patients, but the industry is looking at patients who are coming out of acute care settings. I think that we're seeing more starts of care than we would be seeing recertifications. The patients who are not necessarily in acute danger and aren't being hospitalized are being recertified the way they've always been recertified. So we're not seeing a necessary reduction in that. But I do think that the starts of care are because of the degree of illness some of these patients have experienced and the number of patients. We're seeing the statistics on the news every single day. So we know that there are many more patients that are much more critically ill and much more acutely ill than we had seen in the past many number of years, as long as I can remember. So I think that probably is one of the reasons for that. So that probably will taper off, and we're going to see some adjustments to the hospital without walls will take an effect on what we see in the next few years. There'll be a number of things that are going to change as a result of what we've seen in this past year and a half. And again, like I said, I think it's a really exciting time for folks who have listened to me speak over the past number of years. I used to say this, not that I had a magic wand or I had any kind of a crystal ball, but I used to say 2020 is going to be when home care really shines. Well, it sure did. We had no idea that we were going to shine the way we did, but we certainly was an avenue for patients to go to. They don't want to go back into the hospital. And most patients have learned a lesson over this past year and a half that probably hospitals are a place that they would like to stay away from, primarily due to infections and that kind of thing. So I believe that from this point forward, home health care and men hospice too are going to be the place where folks are actually going to seek for care when they can utilize the care that we have in the home care setting.
I agree, Arlene, and everything we're seeing and reading is that people want to receive care in the place that they prefer most, which is their own home, right? So this has really worked out, I think, better for consumers of care as well as the providers. And I think that the new structure under PDGM is something that's giving providers, guidelines to be able to provide care in the most appropriate way and in a very compliant way. And I think that some providers of home-based care actually did quite well under the PDGM model as opposed to the PPS model in years past. So what do you think we need to do as an industry? I know that our national associations and our state associations are working very hard to make sure that CMS understands what just came out in this Dobson report and what providers are actually sharing with CMS in terms of this was the experience, and we do not need any additional reimbursement cuts to home-based care. We need support of home-based care. We need to be able to have reimbursement for telehealth visits, in addition to increased reimbursement for Medicare and Medicaid clients receiving home-based care. So, beyond the advocacy that's already ongoing with our associations, do you have any other thoughts about messaging to CMS so that we can do exactly what you just mentioned, keep people receiving care in the home?
I believe my greatest piece of advice for agencies is to join those state and those national associations, because it's so important that we get our message out there, and telling those stories and what's happened to us during the pandemic period and how we actually help the nation recover. I think you're going to find that there are going to be stories coming out for years to come, and how home care nurses and therapists became heroes for a number of patients that are out there. So I think getting the word out, getting your message out, letting the government know exactly how you as an agency impacted not only the cost of care, but the outcomes for the patient. So we've had patients that have had tremendous outcomes, despite what we went through in this past year and a half. So I think as we move toward value-based purchasing, we're going to see the need for in-home care just really explode. And the way we deliver the care, the different types of things that we deliver. And I know that Axxess is really, really involved in expanding the way we deliver care in the home. And it's just such an exciting time for all of us. And I think we have no place to go but up. And I think the government's looking at us as an answer to the problem now, rather than the problem itself. And home care has always struggled to have a place at the table with CMS. And I think that over this past year, they found that they are probably getting closer to the head of the table. And it's a really exciting time to be in this industry.
Thanks, Arlene. I agree as well. And I think that you had mentioned, kind of a united industry voice that's constantly advocating and informing and educating our policymakers is critical to making sure that, we can continue to build on the positive things that have come out of COVID in terms of the increased use of home-based care and the terrific outcomes that it's achieved, as well as cost reduction by CMS and private insurers and actually consumers themselves. So thank you so much. Just have one last question. I know that you often consult privately with a lot of home-based care leaders across the nation, and you've been in this business for many, many years and really helped watch it grow. Is there anything that you would say or any advice that you would have to leaders of home health or hospice agencies in terms of either how they can recover from some of the challenges or losses of this past year in terms of PDGM, or if they actually did quite well and they created systems so that they could become more efficient and better in terms of coding and working with clients to continue that? So any last thoughts in terms of advice?
Well, I do think that we need to take a look at how we behaved, what we were ready for in the past year and a half, what we weren't ready for. Of course, the pandemic was very impactful, but I do believe that we had room for improvement as far as PDGM itself is concerned, even in the beginning of 2020. And I continue to believe that there's still more education to be done. I would encourage leaders in our industry to continue the PDGM education. I think our focus is coming off of the pandemic right now, and I think that we need to get back to the business of taking care of our businesses now, and knowing that we are the star that's come out of the pandemic, and that we are going to shine brighter than we ever have before, and that the leaders in this industry have such, there's a great need for the leaders in the industry to show how they can support the home health aides, the therapists, the nurses that are out there. It's been a hard job, and to thank all of those people over and over again, I think we'll probably never be able to do that enough. But again, I think that home care is the star that came out of this whole situation. I think PDGM is just something that we have to work with. The no-pay wraps don't seem to have bothered people very much as far as I've been able to see. Now, we may see more of that come out in data in the future, but I don't think that's impacted a whole lot. But PDGM, certainly we're going to settle down, and that's going to become a focus probably over in the next year. And I just encourage everybody to just look up, be proud of what we've done, and look forward to a great future.
Thanks, Arlene. You're so inspiring and you're so helpful. I really appreciate it. I think that what you mentioned in terms of the real heroes, the true heroes, are certainly the workers. They're certainly the people that are out there on the front lines every day. So I think that these types of things are really critical to making sure that we continue to deliver as an industry, making sure that we have employees that are satisfied with their role, are doing things that they feel that are helping and moving us forward as a country, and doing the right things so that they feel personally satisfied in their role, so they can continue to help us build this home-based care movement that's really taking on the country. So I appreciate your input. I appreciate everything that you just shared with us. Just want to thank our LinkedIn Live friends for joining us today and watching this segment. And if you have any comments or questions that you've left in the chat, we'll certainly get back to you if we haven't answered them today. We also have PDGM resources online here at Axxess, so make sure that if you would like to learn more, you can go to axxess.com and take advantage of all of those free resources. So keep posted. We do Axxess LinkedIn Live discussions from time to time. Make sure you check back and visit us for another LinkedIn Live session. Thank you all for watching us. Arlene, thank you for participating, and everybody enjoy your day.
It's always good to know I'm on my way home. I got you on my mind wherever I roam. So many ups and downs, but there's one thing I know. I'll be with you soon, I'm on my way home. I'll be with you soon, I'm on my way home.